Oh, I've got 3 name cards in front of me. Let's see, myself, Tony, and Dan. There we go. Although you all know who I am, so I don't need to do it. So good morning, everyone. It's nice to see all of you today. So yesterday, I meant to tell you a very short story. So back in the late 60s, when I was in the Bay Area, which, as you may know, was a rather progressive place, my Kaiser physician sent me to an acupuncturist because I had a bursitis in my elbow. And he said, we don't know the long-term side effects of the anti-inflammatory, so why don't you try that first? And I had a bursitis from overplaying at the piano. Then my piano instructor, because I was, slumping a little bit, as we tend to do, said, I think you should see a chiropractor because you're going to be at this instrument for many decades, and it's very important that you learn how to have really good posture. And then one of my skiing buddies, because I was whining about some tight muscles, even though I had done my stretching, said, have you tried deep tissue massage? So in the late 60s, I was very fortunate that people really introduced me to what I would call preventative medicine and how to keep one's health and well-being. And right away, I could see that putting together teams, which started with my Kaiser PCP, was a very valuable experience. So I was on a trajectory to be in higher education. I'm not a practitioner, and that's how I got looped into what I feel very passionate about, which is how do we create patient-centered care. And as we all know, we're very unique individuals, and since I experienced such amazing results with a team of the entire plethora of physicians and practitioners that we have that held the philosophy of try less invasive before you go to more invasive. It's wonderful that I think many of us now have come to this conclusion today, particularly around the issue of the non-pharmacological treatment of pain, but I think in general dealing with our patients and with our colleagues. So again, the basics of interprofessional education, and I think this definition is so important, is how do we create an egalitarian, collaborative, team-based, truly patient-centered care. And Scott Reeves used the term egalitarian, the late Scott Reeves, because it's often when you're with a team, it may end up being shared leadership. It can really depend on who takes the lead of that team at different times. I think many of us know that about 75% of our $3.5 trillion is spent on preventable conditions. And if we start preschool around a lot of these issues, and then we really work together on how we prevent a lot of these and focus more on health and well-being, and then indeed life will happen, and illness happens and conditions happen. So how our philosophy and how we approach this is so very important. So the concept of shared leadership, as Ben was saying yesterday with his daughter, is really becoming very compelling to this next generation. The challenges we're finding in some of the barriers, remember the acronym, anybody? Thank you. TERF, ignorance, and economics, not a small thing. It's kind of the elephant in the room always, it seems. Until we start really reimbursing for prevention, health, and well-being, which I know will be talked about in the next session, I know we'll all be facing a lot of challenges. So when you train the team, it actually can start very simply. Just in the first year, I would bring together our students. I was head of a traditional Chinese medicine school with acupuncture, Chinese herbs, etc., because the practitioner I saw in the 60s made such an impact on me. So when you first bring together your first-year students, even with first-year medical students, they share their vision. They still have empathy. They still have compassion. They still have caring. They still have their vision of why they have come into their respective fields. They share what their passion is, why they came together to learn. The other thing they're finding with teams is it is much less stressful if you're working in a team than working solo with really difficult chronic cases. So I think there are a lot of benefits to team-based care, and certainly as we heard yesterday, and we heard it from Scott saying over and over again, out of the silos, be team-based. And I think that's very relevant. And the other thing that one does right at the beginning is, I found, was talking about evidence-informed practice. So evidence starts to become the thread, and it's really the research, a collaborative research, that builds the bridges amongst our fields. And the reason that's so important is within a successful team, a truly successful team, there's a tremendous amount of respect for one another, trust for one another, and people, all the various practitioners, having a genuine sense, an authentic sense about where their strengths are and where they may not have as much strength. So you put a team together and you really get a much stronger outcome. So yesterday we heard from Scott, which was really an excellent example of how we're going to be moving forward today. And we heard another, I think, really good one from Ben about some successful collaborative projects. And I was really surprised to hear from Nancy about the barriers for OT. I tended to think that it happened mostly to the complementary and integrative health discipline. So that was fascinating. So I think one of the things we talked about in a small group last night, which because we were in there trying to solve some of the problems that were talked about yesterday, was the VA is in many ways taking a lead in how do we create this interprofessional situation. And some of the integrative medicine centers that tend to be housed at the academic centers, the teaching centers, are also taking leads. And so I think the more we can get particularly those two areas to start setting the model in the U.S., because that's the area most of us work in, then I think it will begin to move outward. And again, we'll hear later from some insurance companies, I'm watching my light this time, some insurance companies about how they can set the model as well. Because if they're more and more successful in how they reimburse and how they access, which was one of the really great benefits of the Affordable Care Act with the organizations that they were creating that would do bundled care. So I think that you heard the barriers. The one other point I wanted to make is that right now, because you saw the dates yesterday, 2010, 2011, 2012, is really when we began in the U.S. in a sense, even though it's been done in small areas around the countries for a few decades, is that right now the approach to interprofessional education and collaborative practice is all over the map. And again, I referred you to a couple of websites like the Nexus and also the Canadian Collaborative for examples of what's going on in our respective countries. And there are some great models, but there also is tremendous variation. Some are doing it well, some are not doing it, as I would call it, so deeply. And so I think we can all in that way learn from one another. But at some point, I think as we evolve, maybe 10, 20 years down the line, because we're in kind of the creative phase, it would be helpful if some level, with academic freedom, was standardized for foundational knowledge of what it really means to do, at least the minimum competencies in interprofessional education and collaborative practice to really work in a strong team. Because as Scott Reeves said, it's not about parallel practice. And he's written some excellent articles. I mention his name frequently because he was from the beginning and he was from the UK on this whole area. So it's not parallel practice, which is what we see a lot, practitioners under the same roof. It's really how you work together as a team. So a person comes in, maybe sees 3 or 4 people, and those 3 or 4 people are very well versed in the evidence for that person's particular condition or conditions, and so they can have the dialogue on what their potential approaches are, like Alicia was mentioning yesterday as well. There can be some choice, and there does need to be some education that goes back and forth. I'm sure many of you know now that your patients come in with great studies. So it's also the providers being actually, I think, up to date and really well prepared for that particular situation. So today we are going to move on, and we're going to be talking about the first session is going to be about discussing potential next steps to improve training and education for pain management within and across health professions. Again, it's that within and across that I think is so important. And then we're going to go on to have some excellent models of collaborative practice and how does one really facilitate a team-based approach to pain management. So I would like all the speakers this morning to come up as I introduce you. First, there is going to be Michelle Myers, who is the Executive Director of Research and Innovation at Northwest Health Sciences University in Minneapolis, Minnesota. and she will start us off. And then the other speakers could come up as well. There'll be Dr. Judy Watt-Watson, who is a professor emeritus at the University of Toronto Bloomberg Faculty of Nursing, senior fellow of the University of Toronto Massey College, and an associate scientific staff of the Department of Medicine at Mount Sinai Hospital. And I think I mentioned to you yesterday, not only does IPEC have some excellent training, the University of Toronto does as well, and there are other universities also. Then we'll have Dr. Liz Harrell, who is a director of Student Health Outreach for Wellness, it's called SHOW, and an assistant clinical professor in the College of Nursing and Health Innovation at the Arizona State University, and I know you're going to be fascinated with both of their projects. And then as a discussant, we will have Dr. Ben Kligler, who is the founding national director of the Coordinating Center for Integrative Health of the U.S. Veterans Administration. You'll get to know Ben very well before we're over here today. And so please welcome all of our speakers, and I will be the timer, so I will be over here.